Now my pleasure to introduce our next speaker, Dr. Irene Headen. We at Race to Better Health are so lucky that she's currently serving as a contributing member of the research development team and as a strategic advisor to innovation and collaboration. But beyond that, and perhaps more importantly, she has a full-time job as an assistant professor of Black health in the Department of Community Health and Prevention at the Drexel Dornsife School of Public Health. She's a trained social and perinatal epidemiologist, and her research investigates the social and structural determinants of racial and ethnic inequities in adverse pregnancy outcomes, focusing on identifying neighborhood and community factors underlying these inequities and understanding how system science methods can help translate these factors into multi-level interventions to improve Black maternal health outcomes. She received her doctoral degree in epidemiology from the University of California, Berkeley in 2015, and continued on to complete postdoctoral fellowships at UC Berkeley and the Drexel Urban Health Collaborative. She is also a proud alum of MIT, and we're very happy to have her here today.
Well, thank you, Lydia. And that was definitely a mouthful of an introduction, true to my academic roots. So I have a few slides. I think they're embedded in the this group presentation, or Freddie, should I? Oh, excellent. These are my slides. Wonderful. So as Lydia mentioned, the bulk of my work and my training has been embedded in this context of understanding the root causes at a population level of adverse outcomes, particularly for Black American women, across a number of different pregnancy outcomes over the course of childbearing. So my goal with this presentation is to give you kind of a 30,000-foot view, a bit of level setting for the insights and the contours of the problems that you'll be solving with these amazing, innovative, and tech solutions, and hopefully give you seeds of challenges to overcome outside of the problem, but kind of more around the context shaping and scaffolding that problem, the ones that were mentioned in the previous presentations, that will be critical in testing and ensuring that the technologies that are advanced actually respond to and are used by the populations that need them most. So I will dive in. Next slide, please. And because I'm an epidemiologist, I'm mirrored in data and studies all day, I always like to start my presentations with kind of the why of it. And the why is often never in the data, but really in the stories and the women in their families and communities that are disproportionately and historically impacted by these disproportionate adverse pregnancy outcomes over time. And I think, in 2017, the investigative journalistic expose that ProPublica put together on lost mothers really reinvigorated and reignited the prioritization of disproportionate impact of maternal mortality for Black women as a national crisis. For me, the stories that I carry with me in doing this work are those of Kira Johnson on the left, Shalon Irving in the middle, and Erica Garner on the far right. Kira, they all come from different walks of life. Kira Johnson was, a lawyer and worked in DC, was connected in that society. Shalon Irving was actually a lieutenant in the public health services, working on solving these complex health disparities problems across the care continuum and the disease continuum over, Black populations' lives. And Erica Garner is the daughter of Eric Garner, who was murdered by police in 2015 with the famous last words of "I can't breathe." All of these women also are joined by the unacceptable similarity that they all passed as a result of complications during pregnancy and childbearing, often that were a result of their voices not being heard and being embedded in a context that does not often recognize their humanity, both at the childbearing window, but over the course of their lives. So these are the stories that really hue the context of, next slide, please, Freddie, the multiple adverse outcomes that occur for Black women over the course of childbearing. So maternal mortality captures the most dire and the most urgent outcome that we want to avoid, but even starting before pregnancy, in terms of the 50% higher risk of maternal obesity that Black women face. going on to the 40% higher risk of hypertensive disorder during pregnancy that Black women face. All of that accumulating, of course, within the context of other care criteria, into a 2 times higher risk of severe maternal morbidity events during and after the course of delivery, as well as was mentioned previously in this presentation, or in this session, the 3 to 4 times higher risk of maternal mortality that Black women face. These disparities go on to impact Black infants as well, with them having a 2 times higher risk of low birth weight or small for gestational age, a 50% higher risk of being born early or preterm birth, and a twice higher risk of infant mortality or dying during the first year of birth. And so we can see it's not only at these critical endpoints that we absolutely want to avoid, but it's really this context of adverse disease outcomes, both just prior to, over the course of, and subsequent to the delivery process that really shape the contours of the disproportionate impact of adverse pregnancy outcomes on Black women. Next slide, please. And most critically, for what I think is needed for innovative solutions at the current moment, is the fact that these racial inequities in adverse pregnancy outcomes also impact long-term health trajectories. So here, one of the models that really is at the foundation of my work is the life course model, which was put forward by two foundational epidemiologists decades ago. But it really says that it's not only just this critical window of pregnancy that acts as an uncovering event for a lot of subsequent life course events, but it's really also the accumulation of lifelong adversity that's disproportionately distributed between Black and white populations that really kind of is encapsulated both over the life course, uncovered during pregnancy, and then continue to be amplified by our lack of being able to kind of wrap that care system, wrap that contextual system around Black birthing people during and after that kind of window of pregnancy. And so Black women are rather just kind of on a global scale, women who gain too much during pregnancy also have increased odds of midlife obesity. Those odds are increased by 64%. Women experiencing hypertensive disorders during pregnancy also have an increased risk of adverse cardiovascular outcomes, and that risk is increased by 80 to 210%. And furthermore, 70% of women with gestational diabetes go on to develop type 2 diabetes in their lifetime. And so when we're thinking about how we optimize solutions, how do we hack solutions, I think this is a critical contour of the problem that needs to be highlighted in these solutions, especially for disrupting the disparities that impact Black women, both during the childbearing context, as well as over the life course. Next slide, please. And a critical element of this is that, again, this is from my population epidemiology perspective, but I think is a really critical frustration of both the medical and the public health field, is that knowledge of risk factors has not yielded reduction in inequities. So we've put millions of dollars, huge studies, and really well done studies to identify a whole host of risk factors across the healthcare context, patient characteristic context, clinical factors, sociodemographic factors, and environmental factors. But there's still challenges in the fact that these innovations often don't translate from either clinical context or even public health context to solutions that reduce inequities at the population level. And so to give a real kind of visual implication of this kind of gap, next slide, please. I think these two graphs for me really hammer down the problem. And it's the fact that this host of medical and public health research that we've done over the past decades that have identified these risk factors have done an excellent job of reducing these red, blue, and green lines. And these are the population level rates and incidence of maternal mortality on the left and infant mortality on the right. And so as you can see, for Black populations, the total population, and white populations in green on that lowest line, for both maternal mortality and infant mortality, investing in these interventions has reduced population rates. And these end at 2007, but these trends continue on to the current day. But as we've gotten these gains in reducing population level rates of these adverse outcomes, these have often exacerbated the extent of inequities in these outcomes. And it's really innovations to optimize the reductions of this gray and the blue lines that really are the crux of the challenges facing all of us really embedded in solutions for these problems. Next slide, please. And for my work, and a lot of the work of the social epidemiologists that I work with, one of the innovative research approaches that we've been advocating and advancing over the last few decades that have been mentioned in many of the presentations are placing women back into their context. Health doesn't happen in a vacuum, as was very clearly articulated in the previous presentation. Women and families are embedded in social relationships, they're embedded in living conditions, they're embedded in neighborhoods and communities, institutions, and economic policies. And further, next slide, please. In considering these contexts, racism is baked into each of these levels in not only kind of separate ways, but in ways that iterate and amplify racism experience across different levels. So what I mean by that is that neighborhood or racism experience in institutional contexts such as employment can actually feed back into shaping the contours of the neighborhood ecosystem that Black populations and Black birthing women are navigating over their life course. So there, you're not just necessarily having this additive factor of racism based off of, say, redlining in the neighborhood context and racism based off of exclusion from job access in the employment context, but you really have these feeding off of each other to recreate racially disparate context, again, in which Black women and Black birthing people are trying to navigate and amplify their health, their pregnancy, healthy pregnancy outcomes. And so in thinking of racism baked into all of these contexts, I do want to give just a plug to just like maybe some kind of seeds of wisdom to cultivate over this kind of hackathon. I know there'll be great ideas, but on the next slide, I really kind of think these are seeds. I want to show seeds of, I think, I guess, light in terms of how do we actually operationalize the fact that women are embedded in context and racism is embedded across all of these contexts into actually effective technological solutions. And one of those has been, advances has been in the context of implicit bias. There have been many kind of health tech and apps that really are driven by the stories of Black women, optimized based off of the use and the context in which Black women will use these applications in order to really call out implicit bias, as well as create kind of structures that can allow women to circumvent the implicit bias that's baked into the system while we're fixing the actual system. So applications such as May, which is like a platform that links Black women and Black birthing people with culturally competent care, it's one of those structures that says, while we're fixing the healthcare system and while we're fixing also the public health system that has racism baked in, how do we link Black women with culturally competent care that reduces the experience of racism across multiple levels? There's also been advances by a team out at UCSF to advance one slide back. Advances in how we even measure, how we even conceptualize what does it mean to measure obstetric racism. And I wanted to highlight this because I think how we define the problem is critical to how we develop technologies to solve that problem. And so these are two kind of, I guess, seeds, breadcrumbs that people can kind of follow as they're kind of getting inspiration to how to kind of move forward innovative solutions for this hackathon around improving outcomes for women in pregnancy during that childbearing window. And I do want to end on my final slide with I guess, a perspective that I always bring to my work. And it's actually that, as Ruha Benjamin, the great sociologist and anthropologist, kind of discusses in her Race After Technology book in much detail, race itself, if we think about it in the way in which it's had a productive life, and not productive in a good sense, but in terms of generating racial inequity in our societies, race itself is a kind of technology. It's one designed to separate, stratify, and sanctify the many forms of injustice experienced by members of racialized groups, and one that people routinely reimagine and redeploy to their own ends. And I think that's critical to how we think about who's using the innovations that we create, how they're being used, and again, how they may reinforce unintentionally the bias that's embedded across different sociological and societal levels. And so from that kind of insight, solutions must acknowledge the historical context that's created these racially biased and racially stratified structures and processes. And solutions must center the lives and knowledge and wisdom of Black birthing people in their communities. Again, themes that have been amplified, and I'll just put in an additional plug for as you're kind of developing innovative hacks to improving maternal health as critical to the success of those hacks and actually reducing those inequities and actually reducing that gray and that blue line that I presented in previous slides. And so with that, hopefully I've seated you with a lot of insight, also a lot of questions, and I'll hand it back off to Freddie to continue our kickoff.